Arrhythmia Investigations. This is a brief outline of the investigations used in patients with arrhythmia, each will then be discussed in detail in the appropriate context. Surface electrocardiogram, ECG. Ladder charts or diagrams, Lewis lines. Special leads for P-wave recognition. Continuous monitoring. Exercise testing. Signal averaged ECG, SAECG. Heart rate variability, HRV. Baroreceptor sensitivity testing. Electrophysiological studies, EPS. Surface electrocardiogram, ECG. The 3, 6, and 12-channel modern ECG machines, with 1 or 2 lead rhythm strip, are enough for the diagnosis of most types of arrhythmia. Analysis usually requires the recognition of P-wave and QRS morphology, their relative timing, and their vectors. Complex arrhythmias, however, may need other tools. Recognition of P-wave and QRS morphology, their relative timing, and their vectors, helps diagnose most types of arrhythmia. Ladder charts or diagrams, Lewis lines. Atrial, A line, and ventricular, V line, are diagrammed first. The A line is drawn in the upper tier from the beginning of P, and the V line in the lower tier from the beginning of QRS. A middle tier, AV, in between represents the atrioventricular, AV, conduction. Time is indicated by the slope of the line. The site at which the impulse begins within the upper, middle, or lower tiers, may be represented by a black dot. A blocked impulse is indicated by a short bar at a right angle to the line indicating the direction of conduction. Aberration is shown as a pair of slightly divergent lines. Beat 1, P-wave chart. Beat 2, P and QRS charts. Beat 3, full impulse chart. Beat 4, full impulse with aberration. Beat 5, AV junctional block. Beat 6, AV junctional impulse with anterograde conduction down to the ventricles and retrograde conduction up to the atria. Beat 7, AV junctional impulse with anterograde conduction and retrograde block. Beat 8, AV junctional impulse with anterograde and retrograde block. Beat 9, ventricular impulse with retrograde conduction. Special leads. Special leads may be used when the standard ECG does not provide sufficient information to establish a diagnosis, usually due to inability to identify the P waves. If the P waves are not obvious, alternative leads and some maneuvers can help, such as vertical parasternal bipolar pair, Lewis lead, esophageal lead, using an electrode wire or nasogastric tube, right atrial recording, by an electrode catheter in the right atrium. Invasive electrophysiological study, EPS. This is a demonstration of Lewis lead recording. Right arm electrode, red, is placed in second right parasternal intercostal space. Left arm electrode, yellow, in fourth right space. Right leg electrode, at right subcostal margin. Left leg electrode, at left subcostal margin. Continuous monitoring. Continuous monitoring using Holter monitors, event recorders, in-hospital monitoring, or transtelephonic transmitters, may improve the diagnostic yield of ECG. Exercise testing for arrhythmia is useful for evaluation of antiarrhythmic therapy, evaluation of chronotropic incompetence, evaluation of AV block. Exercise improves AV node conduction, due to vagolysis and increased sympathetic drive, while it worsens infranodal block due to increased rate of impulses conducted to the His-Purkinje system. Assessment of the refractory periods of bypass tracts, when pre-excitation disappears, at heart rates just faster than 100 beats per minute, this indicates a low-risk bypass tract, which will not conduct rapid supraventricular rhythms. Signal averaged ECG, SAECG. SAECG employs high amplification techniques, to record low-amplitude signals, occurring in some patients at the end of the QRS complex, and/or, on the ST segment, which are not visible to the naked eye, on the standard ECG. SAECG provides information on the probability of life-threatening arrhythmias. Its usefulness is augmented when used with other risk estimators, such as Holter monitoring, and left ventricular ejection fraction. Procedure of SAECG recording. SAECG is recorded in the supine position, using an ECG machine equipped with the SAECG software. Unlike standard ECG recording, which requires only a few seconds, SAECG recording requires 7 to 10 minutes, as the machine must record multiple subsequent QRS potentials, to eliminate noise, and obtain a statistically significant average trace. For this reason, it is important for the patient to lie as still as possible, during the recording. In SAECG, 3 orthogonal leads are usually used: horizontal, vertical, and anteroposterior. The commonly used SAECG leads are shown. A horizontal lead, red, with electrodes placed in the fourth spaces at mid-axillary lines, a vertical lead, blue, with electrodes placed in the suprasternal notch and the left anterior superior iliac spine, and an anteroposterior lead, black dots, with electrodes placed in the left parasternal space and directly posterior. Noise sources in SAECG recording. Skeletal myopotentials. Electrode skin interfaces. Amplifiers. Power cable current, which has a frequency of 60 Hz, that is 60 cycles per second. Averaging. Temporal averaging is commonly used, in which multiple highly amplified QRS complexes are summed over time, but spatial averaging is also possible. For effective averaging, the waveform must be repetitive, and must have a common reference point, so that averaging of similar sampling points can be achieved. And noise must be random, or unrelated to the cardiac reference point. If the heart rate is a multiple of 60, the power cable noise, which also has a frequency of 60 Hz, is not diminished by signal averaging. Noise reduction. Noise reduction is proportional to the square root of the number of QRS complexes averaged. For example, 100 complexes obtained result in noise reduction by a factor of 10. Filtering. After temporal averaging, the complexes are filtered to eliminate low-frequency components of the QRS complex and enhance the detection of high-frequency low-amplitude signals, corresponding to disorganized wave fronts of activation. Low-amplitude signals. The high-frequency low-amplitude signals are called ventricular late potentials or ventricular after potentials. They are repetitive electrical events, caused by delayed conduction through diseased ventricular myocardium. Their repetitive nature allows them to be amplified during signal averaging, while random noise is being cancelled out. It is of note that the ventricular late potentials, ventricular after potentials, represent abnormal ventricular conductivity, with delayed conduction, and delayed fragmented activation of diseased ventricular myocardial regions. After depolarizations, triggered activity, on the other hand, represent an abnormal mechanism of impulse initiation, and they occur in both atria and ventricles. The recorded SAECG signal. SAECG recording yields a single averaged QRS potential, usually printed in a much larger scale than the standard ECG, upon which the SAECG software performs calculations to reveal ventricular late potentials, which are small variations, typically 1 to 25 microvolts, in the final portion of the QRS complex. These potentials are interpreted by comparing results with cutoff values. In patients with ventricular late potentials, the resultant SAECG signal is composed of two components. A high-gain, high-frequency QRS complex, called the vector magnitude complex, VMC, followed by high-frequency low-amplitude signals representing the ventricular late potentials. Vector magnitude complex, VMC. Once the ECG complexes have been amplified, averaged, and filtered, they are combined mathematically, yielding an average trace, that is the vector magnitude complex, VMC. This is the single complex from which the analysis for ventricular late potentials is made. Abnormal, positive, SAECG. A positive test means that the patient has ventricular late potentials. Before interpretation, make sure that the standard QRS duration is normal, up to 100 milliseconds, to apply the cutoff values. In the presence of wide QRS complex, such as in bundle branch blocks, the use of SAECG is generally not recommended, although some recommend different cutoff values, for a positive test in these patients. Positive test. To consider the tracing positive, in patients with normal standard QRS duration, up to 100 millisecond, a prolonged total QRS duration is required, together with at least one more criterion. Many authorities would require all the following three criteria. Total QRS duration, QRSD more than 115 milliseconds. Low amplitude signal duration, of the terminal portion of the filtered QRS under 40 microvolts, LASD more than 39 milliseconds. Root mean square voltage, of the last 40 milliseconds of the filtered QRS, RMS 40 less than 20 microvolts. This figure shows a normal SAECG recording. The first step is to make sure that the standard QRS, STD QRS, duration is normal, less than 100, in our case it is 94 milliseconds. Then SAECG interpretation is possible. Total QRS duration is 85, which is normal, less than 115 milliseconds. Low amplitude signal duration, of the terminal portion of the filtered QRS under 40 microvolts, loss, is 21, which is normal, less than 39 milliseconds. And the root mean square voltage, of the last 40 milliseconds of the filtered QRS is 108.1, which is also normal, more than 20 microvolts. This figure compares a negative, left, to a positive one, right. In the positive test, the low amplitude signals, loss, are shown at the end of the tracing. Significance of SAECG. Delayed activation represents a pathophysiological marker for susceptibility to ventricular arrhythmias. It results from fragmented activation in an area of delayed conduction, which is a well-established substrate for reentrant arrhythmias. SAECG is a good negative test. When negative, it indicates a low likelihood of ventricular arrhythmia. Clinical use of SAECG. SAECG is most powerful as a negative predictor of risk of ventricular tachycardia and fibrillation, in the following conditions. Post-myocardial infarction. Prediction of successful ablation for intractable ventricular tachycardia. Syncope of an unknown cause. Heart rate variability. Heart rate variability, HRV, studies provide estimates of sympathetic and parasympathetic balance. While high HRV is associated with efficient autonomic nervous system mechanisms in healthy individuals, low, blunted, HRV is an indicator of abnormal and inadequate adaptations of the autonomic nervous system, which may be associated with increased mortality and morbidity. HRV is blunted in subgroups of myocardial infarction and cardiac arrest survivors, who appear to be at increased risk for recurrent events. Autonomic control. Vagally mediated changes in the heart rate are almost immediate, allowing a beat-by-beat control. Sympathetic control, on the other hand, is associated with longer delays, and potentially longer lasting effects, than parasympathetic control. Heart rate variability analysis may be in the time domain or in the frequency domain, spectral analysis. Baroreceptor sensitivity. Baroreceptor sensitivity estimates the relationship between the alpha-adrenergic, phenylephrine, induced blood pressure increase, and concomitant fall in heart rate. Following myocardial infarction, a blunted baroreceptor sensitivity predicts an increased risk of ventricular arrhythmia and death. Electrophysiological studies, EPS. In EPS, multi-catheter electrode systems provide simultaneous recordings from many intracardiac sites, and mapping of the sequence of excitation in the atria, AV junction, and ventricles. Intracardiac mapping. Intracardiac mapping procedures permit identification of sites of accessory pathways, mechanisms of ventricular tachyarrhythmias, reentrant pathways or sites of origin of supraventricular tachyarrhythmias. Comprehensive EPS. Comprehensive intracardiac studies used to determine the timing and sequences of activation at various intracardiac sites includes recording of atrial activity, A wave, his bundle deflection, H wave, ventricular activity, V wave. Sites for EPS recording: high right atrium, HRAA activity, right ventricle apex, RVA, or RV outflow tract, V activity, proximal and distal coronary sinus, CSP and CSD, left atrial, A, and left ventricular, V, activity, proximal and distal his bundle, HBP and HBDA, V, and H activity. More detailed and less extensive EPS. More detailed mapping procedures. More sites in the coronary sinus. Sites around the tricuspid valve. Left ventricle can be mapped by a retrograde recording catheter from the femoral artery. Less extensive studies, use fewer catheters and recording sites. Usefulness of EPS. Diagnosis of certain forms of arrhythmia, that is not possible by surface ECG. Distinction between AV block above and below the level of the bundle of His. Distinction between true AV block and pseudo-AV block caused by concealed extrasystoles. Determination of appropriate drug therapy. Testing the efficacy of antiarrhythmic drugs. ECG-guided therapy such as radiofrequency, RF, ablation. Thank you.